A triple arthroscopic attack for the release of neurogenic thoracic outlet syndrome. The first step is to release the suprascapular nerve using a subacromial approach. The anterior border of the supraspinatus muscle is followed until the conoid corticoclavicular ligament is reached. At this point, perpendicular to the conoid ligament, the transverse ligament is identified, under which the suprascapular nerve lies. A blunt trocar is used from the lateral transtrapezial portal to dissect the transverse scapular ligament. The suprascapular artery lies just above the transverse scapular ligament. This is the suprascapular nerve identified just below the transverse scapular ligament. An arthroscopic scissor is then introduced through the medial transtrapezial portal to cut the transverse scapular ligament, and the nerve is now released. The second attack is then followed through pectoralis minor release. While the scope is in the anterolateral portal, the coracoid process and conjoint tendon are identified. The coracoid is exposed using the radiofrequency device through the anterior portal, dissecting the space posterior to the pectoralis major and progressively moving medially until the pectoralis minor insertion can be visualized. Using the anterolateral portal, the upper part of the pectoralis minor is released using a radiofrequency device, allowing visualization of the musculocutaneous nerve and the neurovascular bundle. In the third step, a costoclavicular release of the brachial plexus is performed using radiofrequency device. Resection of the subclavius muscle can be performed to enlarge the space. The medial portal is made 5 cm medial to the anteroinferior portal. The scope is moved to the medial portal. The radiofrequency device is then inserted through the anterior portal and is used to dissect the cords of the brachial plexus. The cords can be identified by following the upper border of the pectoralis minor tendon. The 3 cords are then dissected by carefully cutting the surrounding fibrous and vascular bands. The 2 terminal divisions of the lateral cord, which are musculocutaneous nerve and the median nerve lateral branch, are the first terminal branches to be visualized. To identify the proper anatomy of the plexus, start with the musculocutaneous nerve at the medial border of the conjoint tendon and follow it to locate the lateral cord. Blunt dissection should be done all the time in line of the emerging branches to avoid injury of the nerves. Cautious use of the radiofrequency is advised to remove any adhesions or fibrous bands. Any vigorons manipulations near the plexus can cause neurovascular injury. Suction from the shaver should not be performed near the nerves to avoid neural tissue damage. After retracting the lateral cord, the posterior cord and the subclavian artery could be clearly identified. The dissection is stopped after all branches are dissected and released from any fibrous bands.